Dear colleagues, welcome once again to our regional webinar From Price to People with TB, Navigating Drug Access and Advocacy for WHO Recommended TB Regimens, organized by TB Europe Coalition in partnership with Center for Global Health Policy and Politics and Treatment Action Group within Combat DRTB project funded by Unitaid. Over the next hour, we will look at where we stand today with WHO recommended DRTB regimens, at the evolving landscape of drug prices and procurement, and at the major access challenges still faced by countries and communities. Equally important, we will explore what these developments mean for community advocacy and how we collectively can use this knowledge to push for better politics, better access, and better outcomes for people affected by TB. With this, I wish us all a productive session. After today's event, we will also share the presentations and recording in all available languages with all the registered participants. We have scheduled a Q&A session after the two presentations. In between, please feel free to post your questions or comments in the chat, and do please indicate the speaker you are addressing your comments or questions to. During the presentations, please keep your microphones muted when not speaking and do not share your screens. Before we move to the first presentation, a brief note on how to view slides in your preferred language. In the top toolbar, under Shared Screens, select the appropriate screen, presentation in Russian or presentation in English, meaning you will see slides in the corresponding languages. Detailed instructions are in the chat. If you have any issues with this, please write in the chat and we will respond promptly. And now it's my greatest pleasure to invite Mike Frick, one of the co-directors of TAC's TB programs, to speak on advocacy priorities and what activists need to know about WHO recommended regimens. Mike, the floor is yours.
Okay, thanks very much, Lesia, and a big thank you to the colleagues at TBEC for organizing today's meeting and bringing us together. I've been asked to talk about what activists need to know about WHO recommended regimens to treat drug-resistant TB. And I'm here representing Treatment Action Group. Good morning to everybody from New York. And also presenting as a partner in a Unitaid funded project that's called Ascent DRTB, which is working with countries and communities to improve access to WHO TB treatment standards for drug-resistant TB. So we can move to the next slide. My presentation today is going to focus on information that you can find in a resource that TAG and Ascent DRTB produced. It's called our Activist Guide to Shorter Treatment for Drug-Resistant Tuberculosis. And the point of this guide is really to take the WHO guidelines on drug-resistant TB and break the global standards into local actions and priorities for advocates and communities. So it's a guide for activists that provides key information about the shorter DRTB treatment regimens recommended by WHO. It provides the evidence, it outlines the clinical trials, and it gives you arguments that you need to push for the best available TB treatment in your context and country. So that resource is available on our website and is really the basis of what I'm going to be sharing today. Next slide. So today we're focusing on treatment for drug-resistant TB, which is itself a kind of big category that includes different kinds of things that need different forms of treatment. But DRTB broadly encompasses those forms of TB that are in the red box here. We have TB that's resistant to rifampicin. We have MDR-TB. You've heard of pre-XDR-TB. And then, of course, we have extensively drug-resistant TB. If you just click next one more time. So today's talk is really focused on these forms of DRTB. I think we probably need to have a separate webinar on treatment for extensively drug-resistant or XDR-TB. But today I'm focusing on treatment for rifampicin-resistant, multi-drug-resistant, and pre-XDR-TB. Next slide. And I just want to acknowledge at the outset that drug-resistant TB treatment is not easy, but it has gotten a lot better than it used to be. This figure is sort of complicated, but what it shows is on the right-hand side, what you see in gray color, that was drug-resistant TB treatment in, 10 years ago, when the only option available to people was to take 18 to 24 months of treatment. The regimen was often individualized. There were many, many drugs used, tens of thousands of pills that a person had to take over the course of 2 years. And today, on the left-hand side, in the green and blue colors, you see the treatment options that are now recommended. We have 6-month treatment, we have 9-month treatment, and we've been able to take the duration of drug-resistant TB treatment from 18 to 6 months. We've reduced the pill burden from over 3,000 pills to just over 500. And most important for people with drug-resistant TB, these regimens are all oral, meaning that the drugs are taken by mouth as tablets. There are no more injections. And that was really important because the injectable medicines that were used in the longer regimens were known to cause irreversible hearing loss in a significant portion of people who received them. And these new regimens come without that toxicity and without that risk of hearing loss. So things are better, but they're not perfect. Next slide. Can we move to the next slide? Perfect. So I want to say that when people with drug-resistant TB access diagnosis and when they're linked to the right treatment, the cure rates are very high. But the graph I'm showing here provides information from the WHO Global TB Report, which came out last month. And it provides a kind of sobering wake-up call or reality check, which is that most people with drug-resistant TB still are not accessing diagnosis and treatment. So what the WHO is showing here is in green, the number of people who develop drug-resistant TB each year, MDR-TB or rifampicin-resistant TB. And the blue line is the number of people who are diagnosed, and the red line is the number of people who are actually started on a treatment regimen. And so the fact that there's a big gap between green and blue and red indicates that the majority of people would, or a significant portion of people with drug-resistant TB in 2024 were never diagnosed or started on treatment, according to national health systems. And when we look at the regimens that people with drug-resistant TB are receiving, the WHO report has an even more concerning statistic. In 2024, 34,000 people with drug-resistant TB were started on a 6-month regimen, according to what countries reported to WHO. So 34,000 people of the 164,000 who were treated were started on 6-month regimens. So that means that most people with drug-resistant TB are still being given longer regimens. And this, I think, really illustrates the work that we have ahead of us as community and as advocates to make sure that these shorter all oral regimens are actually available and being used for people who need them. Next slide. So I know that if you joined the TBEC webinar series a couple weeks ago, you heard from Dr. Jennifer Furin, who provided an overview of all of the different regimens and went through the drugs. So I won't belabor the point or spend a lot of time going through specific drugs here, but just to say and to acknowledge that treatment is really complicated for TB. It requires learning about a lot of different drugs. The drugs have these long names, they have these different abbreviations, and it can be a lot. But just a reminder that when you see regimens represented on the following slides, they usually are named in terms of the drugs used in them. So here I'm providing the example of the B-PAL or B-PALM regimen, which is the 6-month regimen that most of us have heard about. And it includes the drugs bedaquiline, pretomanid, linezolid, and moxifloxacin. And if you want to learn more about the individual TB drugs, you can watch the recording of Dr. Furin's talk. Because she goes drug by drug and tells you about the compound, some of their side effects, and how they're used in treatment regimens. Next slide. So this slide indicates recent updates to WHO DRTB treatment guidelines that were made in 2025. And this was a really significant year because it added two sets of regimens to global guidance. Those are shown in red. So the WHO now recommends multiple drug-resistant TB treatment regimens. Two are 6 months in duration. There's the BPAL or BPALM regimen, which most of us have heard about. There's also this newly recommended regimen that goes by the name BEAT TB. And BEAT TB is a 6 month regimen of bedaquiline, delamanid, which is used instead of pretomanid, linezolid, levofloxacin, and then sometimes also the addition of clofazimine. There are also 9 month regimens. There's that standardized 9 month all oral regimen that we've known about for a while, but there are also these new regimens called NTB regimens, which came out of research undertaken by the NTB project. It was funded by Unitaid. And a lot of that NTB research was conducted in this region in Eastern Europe and Central Asia. And it looked at 9 months of giving drugs, including bedaquiline, linezolid, and pyrazinamide in combination with some other compounds. And we'll see those on the next slide. So you can go ahead and move to the next slide, please. Perfect. So these are the regimens that WHO now recommends for the treatment of drug-resistant TB. Dr. Furen showed the same slide or a version of it in her talk, but I'm showing it again just to remind you what they are. And you're welcome to refer back to this if you ever get confused about which drugs are in which regimen. It's a lot to remember. But you can see at the top BPAL and BTB. And then there are three regimens from the NTB work that WHO put into guidelines. And those regimens are now listed here. And then there's the longer all oral regimen. So this begs the question. WHO is recommending around 6 regimens for the treatment of drug-resistant TB. So which one is the best? Are these ranked? Should we be using one over the others? And the challenge here is that these regimens have not been directly compared to each other. So we can't say, based on the result of a clinical trial, use this one, not that one. These have been compared to individualized control regimens, historic controls that changed over time. They haven't been compared to each other. And so that means that we have to talk to patients and have to talk to healthcare workers and we have to work on drug access to think about which regimens are better. Next slide. So to help sort through the issue of which regimen to use and for which patient, TAG and Ascent Partners put out a resource called Options for Treating Drug-Resistant TB, which regimen is right for me. And it basically goes through a series of questions that should be discussed between a person with drug-resistant TB and their healthcare provider before starting treatment to decide which regimen is most appropriate for them. And this is kind of an ideal world. It's the world we want. It's one in which, since no one regimen is clearly better in terms of its ability to safely cure TB, people undergoing treatment have the option and they are able to discuss and consider different regimens, thinking about issues like how long is the regimen? How many pills do I have to take each day? Will I need to come to the clinic more or less often for follow-up tests and for monitoring? What kind of tests will be required? Are there any specific side effects I need to be worried about? Am I taking other medicines for other illnesses that may interact with some of my TB medicines? And what do I need to do about that? So in an ideal world, you'd be able to go through all of these questions and find the regimen that was best for you. But the reality is shown in this black box. It's the world we live in. And the truth is that in most settings, drug availability and pricing, affordability, is likely to drive decisions about regimen use. So in a perfect world, a patient and their healthcare provider decide together and they have all the options available to them. But in the world that we actually live in and work in, it's not going to be like that in most places. Some programs will offer one regimen, some may offer a couple, but it's going to depend on drug availability. And that's why the next talk in today's webinar about drug pricing and access is so important. Next slide. So I don't expect you to read this on the slide. I know the text is quite small, But just to point out another resource that we've released and that you can refer back to about the options for treating drug-resistant TB, this table compares the WHO recommended regimens in terms of their duration, pill count, frequency. So if you ever want to know how they're similar or different, you can just refer to the table. There are a couple things here that I want to point out in the red and blue boxes. The first is that, we're often asked the question, why not just give this 6-month BPALM regimen to everybody and be done with it? Like that would be very easy. Um, and that would be easy, but it would leave out some key populations that need treatment for drug-resistant TB. At the moment, BPAL-M cannot be used for children who are less than 14 years old, and it can't be used in pregnant and breastfeeding women. We're still waiting to generate evidence on the safety and appropriateness of the bertomanid in BPAL in these populations. But children and pregnant women are not left out of the DRTB treatment revolution. They can receive shorter all-oral regimens, either the Beat TB regimens or one of the NTB regimens. So down at the bottom of the table where you see age considerations and pregnancy and breastfeeding considerations, you can see that BPAL-M, it shouldn't be used in these populations, but the NTB regimens and the Beat TB regimens are appropriate. I also want to just point out that one of the challenges of drug-resistant TB treatment that needs to be managed most carefully is liver toxicity. And people who enter treatment with existing liver issues, it could be liver disease, it could be regular alcohol use, it could be hepatitis, are going to need to think carefully about choosing a regimen that works with the condition of their liver and the monitoring required for it. And so this is one of the situations where counseling with a healthcare provider and a treatment plan that really takes this into account, thinking about the TB drugs and how they interact with the liver is really important. All right, let's move to the next slide. I also want to make the point that we sometimes as advocates talk a lot about the drugs, bedaquiline, bertomanid, linezolid, and we forget that treatment is about a lot more than drugs. It's also about the experience of treatment. And so we've also put out a resource about side effects and adverse event reporting and monitoring. It talks about 3 different kinds of monitoring that people with TB should be aware of when they start treatment. The first is what we call baseline testing, and this is the monitoring and the test that you take before treatment begins. And I provided a list of what some of those tests are. It would include an HIV test, a pregnancy test, a chest X-ray, an electrocardiogram to check, the electrical system of the heart. It would include blood tests, so you get a sense of your liver and kidney function. These are things you do before beginning treatment, and they help guide and inform which regimen you select. There are also tests that we do during treatment that we call routine monitoring. And these should be done periodically to assess how people are doing on therapy, their progress toward cure, the side effects they're experiencing, the effect the drugs are having on other body systems like the liver and heart, screening for mental health, and support for adherence, nutritional support, and other socioeconomic challenges and supports that people may need. Next slide. And the third set of testing that we recommend is called symptom-directed testing. This is also done during treatment, and it's done in response to somebody on treatment experiencing a particular side effect or adverse event or having a concern that they want reported to their healthcare worker. And if you go back and watch Jen Furin's talk, she talks a lot about the particular side effects of the different drugs, things to be aware of, from fatigue, shortness of breath, peripheral neuropathy, which is the kind of numbness or tingling in your hands or feet. And the symptom-directed testing should be a part of treatment. And I think we need to do a much better job telling people with drug-resistant TB about the symptoms they might experience and helping them to understand, if I'm feeling this, how do I report it and talk about it with a healthcare worker? Is this just a part of TB, or is this related to one of my drugs? And if it's related to one of the drugs I'm taking, do I need to do something else? Do I need to decrease the dose? Do I need to switch to a different medicine? Is there another kind of medicine I can take to help me with the symptom? We don't do nearly enough work helping people understand the side effects and the actual experience of the therapy that they're receiving. So I think this is really one of my central focuses over the coming years is working on treatment literacy and helping people understand and report side effects. Next slide. I also want to call attention to advocacy to secure what in English we call the five S's. And this is a term and a phrase that I'm borrowing from the late Dr. Paul Farmer, who came up with the five S's to describe what patient-centered care should look like. The five S's stand for staff, stuff, space, systems, and support. And they describe what should be in place to have a quality patient-centered treatment program. So staff is, of course, having sufficient healthcare workers and making sure that they are trained in patient-centered care. Stuff is, the drugs, the diagnostic tests themselves, all those things we usually focus about. Space is really important. It's about having an appropriate, dignified, safe space where people can receive treatment. I think we often in tuberculosis don't pay enough attention to the spaces in which treatment is delivered. Is this an environment that people want to be in, an environment that reassures rather than alarms, where people feel supported and secure in sharing concerns that they may have? So the spaces in which treatment is delivered, I think, is really important. Systems, of course, is about policy, the health systems, the active case finding, meeting people where they are in their home rather than requiring them to come to clinic, and then support, which really has emerged as a key priority. And this is everything that we say should accompany treatment or go alongside treatment: better food, better housing, counseling, mental health support, having a peer network or a social structure that supports you through treatment. We need to focus on all five S's. Next slide. This slide then just shows you the five S's again, but kind of illustrating them and what they might mean for drug-resistant TB. I won't go through this again in the interest of time, so we can move to the next slide. I wanted to share a couple of advocacy priorities for civil society and community groups, and these are taken from the Activist Guide, things that we should be asking for and pushing for in our national context. They include updated guidelines that contain the 6 and 9-month regimens. Our country guidelines should at least be matching the WHO global standards. We should also be advocating for more affordable drugs, especially drugs that are expensive, like bedaquiline, although the price has come down quite a lot recently, or bertomanid, which remains a very expensive drug, as does delamanid. We'll be hearing more about that in the next talk. We should be encouraging research to fill data gaps because although drug-resistant TB treatment is better, it's not perfect and we can do better, but we need research to get there. We should be pushing for diagnosis and drug susceptibility testing. It's not something I've talked a lot about today, but a big part of successful drug-resistant TB treatment starts with accurate and timely diagnosis, and a diagnosis that includes information on the drugs that a person's TB is resistant to. So we need drug susceptibility testing in addition to a diagnostic test. We also need to do a better job monitoring treatment. And a big part of this is, I think, community work from community-led monitoring mechanisms. The community data that's generated is really going to guide program performance and quality. And then we need to create demand for these regimens. I said at the start of the talk that only 34,000 people last year with drug-resistant TB got a 6-month regimen. It's an indication that we can do a lot better in demand creation. Next slide. This is one of my last slides, and I just wanted to share a couple of lessons from the Ascent DRTB project. We've been working with community partners, including TBEC and TB People Ukraine, and partners in other countries to work on treatment literacy and build demand for all oral, shorter drug-resistant TB treatments. And based on those community experiences, these 6 lessons really stood out. But the one that I want to focus on is the lesson that is at the bottom of the screen, and on my screen is a little cut off, but I'll talk through it. That's okay. It's the lesson on stigma. I really have come to understand that if we want to improve drug-resistant TB treatment, we can't ignore stigma, and we have to approach it with a variety of tools. We have to, and this is a phrase I'm borrowing from our partners at KNCV, we have to approach stigma with our head, our hands, and our heart. We have to use all the tools available to us to work on stigma and discrimination if we want drug-resistant TB treatment to succeed and want people to access it when they need it. Next slide. And this is my last slide, just saying that the resources I introduced today are available online. And we're working on translations. And in the coming year, these will be available in Russian language as well as some other languages. So stay tuned for that. Thanks very much. And back to you, Lesia.
Dear Mike, thank you so much for this meaningful presentation. So we see that treatment is more than medicines, yeah? Diagnostics, monitoring staff, space, and comprehensive psychosocial support are all essential and mean a lot. And civil society actually can push on all these pillars. Dear colleagues, before we proceed, may I invite those who are able to switch on your cameras so that we can take a photo to commemorate this webinar. And I will ask my colleagues to help with taking a photo. It can take some time, yeah, because there are lots of us, almost 81 already. Yeah, I will ask stop sharing the screens. Okay, and give me a sign that we are done, please. If you can't switch on your cameras, then give a note in the chat presenting yourself if you haven't done so yet. We will definitely share all the presentations, including photos after this event with all the registered participants. Colleagues, please help me. Are we done with the photo? Okay, I believe we need some more seconds. Okay, thank you for your patience. Great.
Сделано.
Great. Thank you so much for switching on your cameras. It's a pleasure to see all of you. And now, without further ado, I am pleased to invite our next speaker, Sharon Lynch, a co-director of the Center for Global Health Policy and Politics at the O'Neill Institute for National and Global Health Law at Georgetown University. Sharon has over 25 years of experience in global health, humanitarian work, and access to medicines advocacy. And today she will be sharing her presentation with her colleague Agrata Sharma. Her work focuses on strengthening health systems through evidence-based policy, particularly in resource-limited settings. And today, they will guide us on prices of key DRTB drugs and regimens. Unfortunately, Sharon couldn't participate in this event, and she shared a pre-recorded presentation with us.
Hello, everyone. I'm Agrita. I'll be presenting on behalf of Sharnan. As I said, that it will not be half as good as Sharnan's presentation, but I will try and be as comprehensive as possible. So on to the next slide, please. So in terms of our agenda, we have a discussion on the prices of the key WHO recommended TB drugs. This will be followed by the TB pipeline, which means that what are the new drugs that are coming up, what is under research, and then we'll talk through the lessons from the past, followed by the target access profile for this new drug called quabodepistat. Next slide, please. In terms of drug pricing, we will be focusing on three main drugs, that is bedaquiline, pretomanid, and delamanid. The source for the pricing is primarily the Stop TB Partnerships Global Drug Facility catalog, And apart from that, we relied heavily on Christoph Perrin's presentation to find out what the prices are in different regions and how are they varying. Next slide, please. So for bedaquiline, there is this 100 milligram formulation. It's a tablet. So from Johnson & Johnson, when procured via GDF, the price has fallen down to $130. But in China, J&J is giving a price of over $9,000. Then we do have three other generic manufacturers, one being Lupin, which is actually producing it at a low price of $63, and then MacLeod's that is producing it at a price of $90, and then Farm Standard that is actually selling it in Russian Federation area at about $16.50. Now, if you see that the long-term target price that was decided by this group that was brought together by Global Drug Facility was $100. So we are actually lower than the price that we decided in 2024, which is a huge achievement. That is, something that we achieved with the work that all of the activists have done over the years. Next slide, please. So for Protominid, we have three main manufacturers: Viatris or Mylan, that is producing it at $224. Then McLeod's, that is at $238, and Lupin, which is the lowest priced one, which is at $169. Here, we've still not met the long-term target price that was decided in 2024. But it is in line with the cost-based target that was decided, that was actually brought forward by this group of Fortunac and Andrew Hill. Next slide, please. So for Delaminid is still way higher price than the other two drugs. And also I think the one of the reasons is that generic competition has been introduced rather recently. In terms of the pricing, GDF, Otsuka is actually providing this at 1190, which is lower than its previous price of $1,700 per person per regimen. But this price is much higher in China, where the government is procuring it directly from Otsuka, and it's priced at over $21,000. And then, as I said, newer generic competition is coming in, but it has been slower than expected. So from Viatris, the price has, because of the entry of Viatris, the price has come down to $800. And then the Indian government is also procuring it at a low price of $1,840. Nevertheless, when it comes to our farm, the price is still higher than what Otsuka is giving GDF, which is about $1,400. And as you can see, this is way above the COGS analysis that was done years ago, and it is also way above the long-term target price that was decided in 2020, that was discussed and decided on in 2024. Next slide, please. So with that, we change tracks and we move on to what the DRTB pipeline looks like. So the image that you see here is borrowed from Treatment Action Group's TB treatment pipeline report. The drugs that you see inside these boxes are our priority drugs. I think these are very, very critical to what DRTB treatment would look like going forward. So I'll discuss them one by one. Next slide, please. So first is TBAJ 876 or sarfequelin. This is sort of, I would say, like a cousin of bedaquiline. It is more potent. It has fewer adverse effects. The developer is TB Alliance. Right now, it's undergoing the results from the NC009 trial were presented at the Union Conference, and based on that, what we found that it is way more potent. It has fewer side effects. And the phase 3 trial is being planned in 2026. It will focus on South Africa, Philippines, Georgia, and then Tanzania and Uganda. And then it is also being studied to see if it can be used as a long-acting injectable, which is basically a once-a-month dosage. Next slide, please. Sorry, and then on to TBAJ 8587. This is another relatively newer, younger cousin of bedaquiline. Very similar, being developed by TB Alliance. It is still early in phase 1A or phase 1B. And then it is also a candidate for long-acting injectable. It is a part of the Clobber TB trial. It is a 6 to 9 month combination regimen with TBAJ 587 for DRTB and specifically for bedaquiline resistance alongside pretominate, ganfaberol, quabodepistat, and sutezolid. With that, I move on to sutezolid. Next slide, please. So sutezolid is a newer category of drug. The developers are TB Alliance and Sequela. It is in phase 2BC. There is a DSTB and a rifampicin resistant TB clinical trial being run by Gates MRI TBD 06201 to evaluate 4 months of quabodepistat, bedaquiline, delaminate, pretominate, and sutezolid. But the trial was discontinued earlier this year because the interim results showed that the culture conversion was inadequate. And then it is also a part of PAN-TB-HM, which is basically a substitution trial where folks are trying to substitute linezolid for sutezolid. Next slide, please. And then next slide, please. Thank you. Then on to contezolid. It is another drug in the same category. It is a drug being developed by a Chinese pharmaceutical company called Shanghai Mycurex Pharmaceutical. It is less toxic. Studies have shown that it is less toxic than linezolid, and it can be used for people who do not tolerate linezolid well or have contraindications. It also has potential uses beyond DRTB, which includes, soft tissue infections, because of, where the causative agent is Streptococcus pyogenes, Streptococcus, and other streptococcal strains, then Staph aureus, especially that is resistant to methicillin. And then it is under trial, as I said, and it's being sponsored by Beijing Chest Hospital. It's in phase 3. It is a multi-center trial. And it is a substitution trial wherein they're comparing the 6-month regimen by substituting linezolid with contezolid. Next slide, please. So ganfaberol, it is being developed by GSK. It is first in class. The phase 2 is completed. And one of the key flags here is that there is evidence of preclinical teratogenicity. But it has moved forward and it is under trial. And then in phase 2BC, in the 4-month regimen in the paradigm for TB trial, one arm with, so basically this is under trial under the paradigm for TB trial. So that's the main flag. So next slide, please. So the most advanced in the pipeline is quobadepestat. It has started recruitment for phase 3. It is a new in class drug. It is a DPRE1 inhibitor. And the developer is Otsuka. So as you remember, when we were discussing pricing, Delaminid was also developed by Otsuka. So as I said, they're already recruiting for phase 3 trials. The phase 2 trial was completed where they compared quobadepestat, bedaquiline, and I'm forgetting, I think predominant with HRZE. And then there's a probability that it would simplify treatment and even shorter treatment. So Otsuka has started recruitment for Quantum TB trial, which is basically the phase 3 for quobadepestat, and it is assessing if it has efficacy that is comparable to BPAL. There's another one where quobadepestat is being included in a trial, which is Paradigm for TB. I think it's a little bit, it's not visible on this presentation, but it is being conducted by University College London. And the countries where this is being conducted is Moldova, Tanzania, South Africa, Uganda, and Vietnam. Next slide, please. So what are the key lessons that we've learned from bedaquiline and delaminid? So I think one of the key lessons that we've learned is that access has to be built right from the beginning. And then faster scale up is actually a good business decision. We've seen how strongly there is a disconnect between the scale up of bedaquiline and delaminid. Bedaquiline scale up, as you can see in this graph, is like exponentially higher than delaminid, which also changed the way, clinicians, advocates, people, who were there, making those big decisions about what becomes a core drug and what doesn't, that played a very big role, because if people have the experience in using the drug, they would advocate for it. And then the part where secrecy obstructs accountability. So when the licensing agreements, they're not transparent enough, the pricing is not transparent enough, it leads to lack of accountability. It leads to, it's so basically the idea is that the global response is not determined just by lack of scientific innovation. As you've seen that, there is substantial scientific innovation, but the lack of transparency in terms of patenting, licensing, and pricing leads to confusion and lack of and practices that otherwise restrict the ability of making sure that life-changing medicines are actually available to people. And then lastly, people should be able to engage early on with WHO, global health actors, and use EU for all, WHO CRP, and such mechanisms. So next slide, please. Okay, so how do we make sure that the drugs that are in the pipeline actually do better, and there is better access, and how can we make sure that these drugs actually reach from the labs to the bedside faster. So one of the ways is to develop target access profiles. This is some work that Shannon and other people here have been leading to make sure that the products are that access is built right into the development of the product and not an afterthought. And then promote early access frameworks, ensure transparency in R&D costs and supply planning, and then advocate for donor and developer alignment on consistent access commitments. This, I think, is a very, very important part because most of the research has some, donor funding or philanthropic funding or government funding. So how do we leverage that? I think that component is extremely important. And then what is the role of the country? What is the role of the national governments, right? So one is that we need to engage with NTPs and civil society to amplify demand, policy preparedness for future regimens. Next slide, please. So this is what in this slide and the next one, I will discuss what a target access profile looks like. A target access profile is sort of, like a sort of trying to be a twin to target product profile. So WHO target product profiles describe what an ideal product should look like in terms of performance, usability, and sometimes even affordability. But TPPs do not consistently capture access requirements. This is where target access profiles come in and they fill the gap. They give us, as civil society, a structured tool to articulate our access expectations from the very beginning and to hold developers and donors accountable for ensuring that new TB tools reach people quickly, affordably, and safely. This is especially important because so much of TB drug development relies on public and philanthropic funding. So, and then using, so what I'm going to do is basically use Quabbit as an example to walk through the elements of target access profile on this slide and the next one. So this is still under development, and it would be great if you all can contribute to it, add to it. As Yulia and Lesia have been saying, that all of the slides would be shared. If there is something that comes in later, please feel free to reach out to me and with all of your inputs. So first, under innovation and availability, we will discuss populations. So at the introduction, Quabbit must be available not just to adults, but also to adolescents and children. For people living with HIV, hepatitis B, hepatitis C, for pregnant and lactating people, for people with other comorbidities, including substance and alcohol use. At the end of the day, they are the people who are more vulnerable to TB, so they should not be left out of the clinical trials. Followed by, and then about indications, Q should be launched for drug-resistant TB with plans to expand over time to other groups. On drug susceptibility testing, we've learned from delaminid, bedaquiline, and protominid that DST came in far too late. For Q, we expect early engagement with diagnostic developers and timely availability of compounds for phenotypic and molecular DST development. For formulations, we need clarity on companion drugs and whether Q can fit within regimens. One of the things that we learned from both bedaquiline and delaminid is that we need to have greater clarity on how do we combine these drugs, sequence these drugs, what are the contraindications, what are the adverse effects, how do they impact each other, what are the drug-drug interactions. So I think making sure that there is this clarity right from the get-go for Quabbit is very important. And then in terms of formulation, the low dose of 30 milligrams for Quabbit promises us that both formulation and the formulation will be more affordable. And developers must proactively share knowledge, materials, and data, particularly to support compassionate use and expanded access programs. You want to see a commitment to compassionate use starting after phase 2, which is right now, in line with standards set by folks at Better Project, led by people like Dr. Jen Furin. Otsuka needs to make the drug available for program and operational research and not wait until phase 3 results. On to quality and affordability. Registration should prioritize countries where trials were conducted and high burden countries. We expect Otsuka to pursue stringent regulatory authority approval, which is a body like European Medicine Agency, Global Fund ERP review, WHO pre-qualification, especially WHO's collaborative registration procedure, as well as consider EU Meds for All. We've seen the impact that that a procedure like WHO collaborative registration has on uptake, and we saw that during the bedaquiline journey. Although we, can you, okay, so there's a little bit of saying the lower part of the slide is missing, but as I said, I will like Alessia and Julia will share the slides with everyone, so I think you'll have access to it. So although we do not have the cost of good analysis for quabatabstat just yet, but we do know that it is easier to manufacture and package than delaminates, so the pricing should be lower. Next slide, please. Okay, so on to supply and delivery. On IP and licensing. Right now, what we have on the target access profile is that we want withdrawal or non-enforcement of secondary patents and a licensing strategy through Medicines Patent Pool or WHO's Health Technology Access Program. This must include full API access, tech transfer, and non-exclusive licensing that covers not just lower middle income countries, but also middle income countries that are usually left out of all of these licensing agreements. What we also need is supply security. So we need multiple manufacturers, global and regional redundancy, and a supply model appropriate for stop TB partnerships, global drug facility procurement. And then under the suitability and heat stability matter in high burden countries. Then demand and adoption, early access is critical. Compassionate use is expected around next year, September 2026. But it must not replicate the burdensome delaminate experience. There should not be arbitrary exclusions of vulnerable people like adolescents, pregnant people, or others unless justified by evidence. And this is in line with Better Project's call to action, which I will share. And then for national transition, countries will need support for policy translation, training, and incorporation of quabatabstat into newer treatments, and finally financing, which is a very critical piece considering the current global environment. Both domestic and donor funding will be essential to sustain access at scale. With that, I wrap up. This is in short what a target access profile for quabatabstat would look like, and I would look forward to your inputs. And this also outlines what equitable and timely access should look like for not just Q, but also for other drugs that we discussed, and how do we prioritize? What do we prioritize? This is something that we need to, constantly be in discussion with. Next slide, please. Okay, so with that, I conclude. Thank you so much for your attention, and I look forward to your questions and comments.
Okay, thank you very much, Adrata, for taking over Sharon. And I believe, well, not believe, I'm pretty sure that you managed to do it Great. It's a great job. Thank you so much. Dear participants, thank you so much for bearing with us and for staying with us. We're a bit over time, but nevertheless, I would like to ask whether there are any burning questions to our speakers, to Mike and Agrata. I see a raised hand already. Stephen, you're welcome.
Yeah, thank you very much, Lesia, and good morning, good afternoon, and good evening, depending where you are. My name is Stephen Anguva Shikoli, the National Coordinator Network of TB Champions in Kenya. Thank you very much, Mike, and the presentation from Argata was very great. My quick question is that I saw two drugs that are being developed and being supported by TB Alliance. So I'm trying to look at what about the inferiority in terms of uh, what do we think we need to push as ahead of the other one? Because being that they are all brothers of bedaquiline, and they are two different drugs. So and they are being funded by one donor who is a TB Alliance. Is there a risk of having one being pushed more than the other one being pushed more than the other one, or how do we ensure that in terms of our advocacy, we know how to push a balance to ensure that one drug is not marketed more than the other, but we look at the impact and benefit and access. Thank you.
Hello.
Okay, thank you for your
Yes.
question. So, Agrata, I believe that it goes to you.
I think both of them, they're in different
Hello.
stages of development
Hello.
right now.
Hello.
So I think they will come in at different points. So I think we need to advocate
Hello.
for both of them because bedaquiline resistance is a very big issue, and we would have to make sure that both of these drugs are there. And also both of these drugs are great candidates for long-acting injectables. So I think your question is very valid. I think we would need all of your support to make sure that these are pushed out adequately for everyone who needs it. But I think because they're in different stages, maybe it can be tackled in a more straightforward manner.
Okay, thank you very much. Dear colleagues, do we have any other questions to our speakers, Mike and Agrata? I can't see the raised hands. Oh, I see. Sorry. Stephen, is it the next question or the same?
It's the next question. It's the next question, Lesia, and it's to Mike. Thank you very much. Thank you very much, Mike. I know you've presented the advocacy guide that was launched recently, and looking at this new science and new technology that are upcoming, do we think that it is now high time that as advocates and activists in this space to ensure that each year we launch an activist guide that is inclusive of new science and new technology? That's just my maybe a comment or a recommendation, so that every year once WHO does their thing and partners are out here have developed new molecules, we have advocacy guide that is updated on a regular basis, like maybe annually. Thank you. So that every year we expect that TAG is going to launch an activist guide. We have that like in a schedule that at a certain time each year we are launching. Even if there is nothing new, we are just giving an update that we have made progress. Thank you.
Yeah, thanks, Stephen. Our whole idea with the activist guide is that it should follow the WHO guidelines. Sometimes we get ahead of the WHO guidelines a little bit, but generally when there's a big update to global guidance, that's when we would update an activist guide. So unfortunately, we're not yet at the point where the science is giving us something big and new every single year. We're not working that quickly. We're doing a lot better than we were before, but I don't think we'll be yet challenged with updating our activist guides annually. But Lesia, I wanted to respond. There was a question in the chat from earlier from, I think, Tatiana about demand creation, which was a really good question that was basically, okay, if you have a 6-month regimen, who's not going to accept that over a longer one? Like, shouldn't the demand just be very obvious? And I think it's a great point. But one thing I've learned from working on demand creation with community partners, people like Stephen and the TBEC and TB People colleagues, is that sometimes the hesitancy around demand is not on the side of the person with TB. it's on the side of the healthcare worker. And so while a person with TB, given the option of 6 months or 12 months or longer, of course is going to choose six, other things being equal, healthcare workers, change is hard. And to introduce a new regimen, you have to rework a system, introduce a new algorithm, find funding for it, rework a clinic workflow, do new training. And we also have to overcome like what I call hangovers or old ideas that have to be replaced, so people may have hesitancy around using a new drug that they haven't used before. They may prefer an older regimen. Even if the drugs aren't as good, they're at least familiar, so it's easy to use them. And so these ideas take time to change. So on paper, it's totally obvious. Of course, you would go for six, but in practice, we find that advocates come up against all sorts of reasons not to change something. And so part of demand creation is just about actually working with your program to facilitate change. Yeah, I hope that resonates. Thanks.
Yeah, great. Thank you so much for responding this comment. Okay, we have two more questions. First, Paul and then Ola. And I would kindly ask you to be brief if possible, yeah, because we're a bit over time.
Okay.
Paul, you're welcome.
Thank you, Lesia. Just a comment on your last remarks there, Mike. One of the mysteries for me of recent years has been that we have had available and approved by WHO a 4-month regimen for drug-sensitive TB. And yet it is not very much used. There's partly a price issue there, but we as advocates have also not got excited about it. We haven't been pushing hard on it. And it's been a mystery to me, as certainly I've understood that national programs aren't excited enough by a drop of only 2 months, and are happy to stick with what they're used to. But it's also we as advocates have not found many advocates terribly excited by it either. But my specific question actually was to you, Agrata. Just a practical one. You were kindly inviting comments and suggestions in response to the target appraisal for Quavodistat. I wonder, is there an actual sort of letter or something inviting comments with all the stuff that you had on it? Basically, if we want, I am in a place where I would like to get them to make comments on that, but I don't want to be just saying, "Oh, I was on this interesting call the other day." I need something with a bit more detail.
Paul, let me just ask Sharnan the procedure that we want to set in for this. But definitely having people comment on this is very crucial. So I'll write to you about it once I have more clarity myself on the procedure.
Okay, thank you very much. I should perhaps say, Quavodistat, as you mentioned, is already being looked at in the paradigm set of studies under the Unite for TB program, and I sit on the community advisory group for Unite for TB. Thank you.
Thank you, Paul. Thank you for your comment and question. And Ola, you're welcome with your comment or question.
Yes, thank you. Let's say I try to be shortly, and I have some short reflection for also Mike's comment. Thank you for the presentation, and this really interesting and helpful. But one aspect that we not discuss in public when we speak about some new regimes or access countries to provide and implementation these regimes. And I disagree that the question only with medical workers, because what we see that issue is not only about this to transition in process transition to new regimes, and there are also significant barriers related to procurement process and drug disposal. Because this is a different institution in national levels. Often it's a different institution, and experience shows, especially with bedaquiline and Bepal, that the main problem is often the lack of alignment and coordination between these processes in countries level. And from the moment a new regime becomes available to moment people can actually access it, as a major delay occurs, especially if the country still has remaining stock of previous regimes. And this is funds question, this is political questions, and it's I think partly answer to Stephen's question, what communities and civil society can push in their countries. And this, I think, every time continue dialogue with NTP and ministers that about coordination, consolidation, and systematic process between funding for pills, access regimes to local level and to people, and how this transition plan can be more systematic from previously regimes to new regimes. And that's we can start now, before the new regimes will announcement, because this process unregular in a national program, we need more time to provide these changes in laws in a national country before new regimes. And I think if we unite now in this advocacy, we systematic this process, we have a good chance with more positive practice than we had with bedaquiline and delamanid. Thank you.
Yeah, maybe I'll just respond quickly to that. Such a good point, Olya. When introducing a new regimen, you of course have the drugs that the country has procured and ordered for the older regimen, still sitting in the warehouse or in clinics. And it's very political about whether you can destroy those drugs that have already been bought in order to use something new, or whether before you use something new, you first have to use up all of the old stuff that you've already bought and paid for. We have seen this play out time and again. Stephen and I were working on a TB preventive treatment project where we were trying to use the new rifapentine regimens instead of isoniazid. And a country, Tanzania, had ordered a lot of isoniazid, and they said, we want to use this first before we introduce rifapentine. But the community wanted the shorter rifapentine because it was more patient-friendly. It's a very political discussion that has to be had about what do you do with the old drug. And some countries will say, well, maybe we'll offer it to our neighbor. They haven't updated their guidelines. We can just give it to them for free or sell it at no loss. Other countries say, no, we have to use what we bought, because people within the ministry, within the procurement team can get in trouble if drugs are destroyed before they're used when they've already been paid for. So to your point, I think activists have to understand how their governments work, how procurement works. You have to begin the dialogue early. The one thing that's helpful here is that when WHO updates guidelines, they now have a practice that they call rapid communication, where before the full guidelines are out, 4 to 6 months before, they send a rapid communication that basically tells you what's going to be in the new guidance. It's not the full guidance, but they give you a heads up. And I would say, to your point, when that rapid communication comes out, that's the moment to start talking to your government about, okay, we're going to have to buy something new. So what do we want to do with what we already have? What's our plan? Such a good point. Thanks for bringing it up. There's just one more story. There's a country in your region that has ordered a lot of rifapentine for the 4-month treatment regimen that Paul was talking about. And that has actually made the country move everybody to that regimen, more or less. And that's not good either, because we need to be thinking about what is the right regimen for people. It shouldn't be decided just based on the drug we bought. It should be that we buy the drugs we need to treat the people we have. Anyway, thanks.
Yeah,
thank you so much for this meaningful discussion and for this interesting discussion, for raising interesting questions. I believe that we can wrap up now. Yeah. In case you have any questions, further questions, please share them with us. And I'm pretty sure that our speakers, Mike, Sharon, and Agrata, will address them. We will definitely share all the materials, recordings, and photos of the webinar with all the registered participants, along with the response from Agrata to Paul's comment and question about the possibility to meaningfully participate in populating the target access profile of Cubo. Sorry if I'm mispronouncing. It's very difficult, just pronunciation of this drug. Dear participants, thank you so much for staying with us, for expressing your interest, for participating in our discussion. It was a pleasure being here all together. With this, and of course, thank you to our interpreters who helped us to understand each other, notwithstanding any technical issues. So with this, we wish you all happy upcoming weekends, a happy good evening, or a happy good day, good Friday to all of you. Thank you and bye-bye.
Thank you.